我非常荣幸的今天能够跟大家来个谈这个新的方面，跟这个 AI 和 precision medicine, something very close to my heart. And thanks for invitation from Dr. Li and also Superintendent Chu for a fantastic center here, because I visited about 5 years ago. It's actually all brand new and it was just starting in terms of the new areas, and now it's all beautifully finished. Oh my God, I can stay here. It's just beautiful. And it's typical of Taiwan's innovation and progress. This is so admirable. And so just to share with you in terms of thinking about precision medicine and some examples of the areas where we're working on precision medicine and also applying AI, which we heard some beautiful presentations this morning. 我是觉得不好意思，有点这个五班弄斧，因为你们这些都是专家在这里。And so in terms of looking at precision medicine, this is the FDA definition. And in terms of being able to use an innovative approach, into account in tailoring disease prevention. So today we talk very much in terms of the prevention and also treatment, and taking into account people's differences in terms of genes, environment, and lifestyles. And the goal of precision is really actually target the right treatment to the right patients at the right time. And one example of thinking about this is the fact that all the population, for example, 在这里的病人或者是在这个台湾的 population, not all the same, and so that one can actually distinguish, the biological differences, environmental differences, and for example, in terms of whether it's prevention or treatment, that the patient falls into different categories, so we can actually do better for each one of them. And 今天讲的这个很有意思的就是说, maybe we can actually identify early disease conditions in each individual populations at risk. And so I'll just talk about some of the examples, and so I'll give one example on pharmacogenetics, and I know Brian later on is going to talk about genetics. It's going to be a fantastic talk. And also in terms of novel biomarkers to classify patients with heart failure, 就是心衰的这个病人, and a major cardiovascular epidemic. And just a couple words in terms of imaging, and in fact imaging using chest x-ray. And so then also in terms of using precision medicine in health systems. So the vision for precision medicine, very much similar to what we have talked about today as a theme. 譬如说我们假如这个, compare 2023 to what may happen, say 5 years down the road, here at the Yuandong Yiyuan, for example. So let's say you have a 72-year-old gentleman comes in to the hospital in the emergency department with chest pain, and ECG showed ST elevation compatible with heart attack, and high-sensitive troponin shows that this is indeed a heart damage, and that maybe Dr. Adam Lee or colleagues, take the patient to the cath lab, show that there is a blood clot, and that the artery can be then opened up with a stent, and the patient then will take medications. And we'll talk about the antiplatelet agents momentarily. But in 2028, if we actually talk about what we want to innovate and apply, maybe this is what will happen. So the patient, and in this situation, we'll actually have background information in terms of genetics. And in addition, we talk about the wearables, and then nowadays, not only you can have your watch, but you can actually have a patch that can actually measure biochemistry, you can actually measure proteins, and these can be read on your phone or on other devices, and that this, before the patient has a heart attack, in fact, give you the warning, and that there are changes that's taking place that's actually acute, potentially risky. So in this case, you can actually take a very precise prevention strategy tailored to the changes that you actually observed, and then being able to then avert a heart attack and that you can then evaluate subsequently with specific imaging strategies in terms of what might be underlying that. And so you can reverse the atherosclerosis, which is not very good for Dr. Lee's business. Then he won't be able to do the stent anymore. And so in terms of looking at precision medicine, I give an example of pharmacogenetics. This is Dr. Derek So, who's actually an interventional cardiologist, and also Ben Hibbert, and they together, in fact, have devised a bedside genetic test unit that can allow measurement of polymorphism of the drug processing enzymes, pharmacogenetics enzymes in the liver, such that you can actually, while the patient is undergoing angiogram, can get actually a buccal smear, and that in 15 minutes you can actually read out the genetic profile, and particularly in terms of the metabolic enzyme like the C2C19. This is very important for an antiplatelet agent metabolism, clopidogrel, which is the commonest antiplatelet agent we use after angiography. So depending on your polymorphism, and for example, about 30% of the patients have polymorphism type 2 or 3, which will render clopidogrel to be ineffective versus 1 and 17. And you can actually test this and then determine whether the medication is appropriate for that patient. And so this concept was originally published in Lancet, and but then Dr. So and the colleagues from Mayo Clinic and about 60 centers around the world did a randomized trial of looking at the genotype-guided therapy in which we use the measurements to determine the drug versus a conventional in which you just give whatever the doctor prefers. And you can see that, in fact, in terms of looking at the death, heart attack, stroke, that there is a difference 5 times within 1 week of post-angioplasty after a heart attack. And this difference continues on. And really actually shows that knowing this status makes a huge difference in terms of outcomes for patients after a heart attack, and that this is the impact of precision medicine. And so the only downside is that Dr. So is born in Canada. It's not from Taiwan. So he made this device, and this device now is actually bought over by a Dutch company, used for many other applications. But I don't think he made any money from this. And so he now still has to work as a cardiologist. And so one area where actually I'm very interested in is heart failure. And this can happen after a heart attack, for example, in which there's damaged heart muscle, the heart dilates, and the ejection fraction falls. This is called heart failure with reduced ejection fraction. Or in the situation in which a patient has high blood pressure and diabetes, but no heart attack, and in which case the ejection fraction is normal, and in this type of situation, the heart may be thickened, and the patient can die heart failure in either case, and the patient can die from heart failure in either case. And this type of heart failure is getting more common all the time. So the big question is, how do we treat patients with heart failure? And are there better ways for us to characterize the patient? So we can see that for the patient with reduced ejection fraction, that's after a heart attack, now there are many different drugs that can be used. And so the big problem right now is that there are too many choices, and does everybody need this medication? So I think heart failure with reduced ejection fraction is like a Chinese buffet. You have actually many drugs to choose from. Which patient for which drug? Right now the guideline recommends you use everything, right? And the patient says, no, I don't want to take everything. So this is a big problem for heart failure with reduced ejection fraction. And on the other hand, for patients with preserved ejection fraction, there are very few drugs. Right now, there's only one. That's SGLT2 inhibitors. That's empagliflozin or dapagliflozin. And the question is, does everybody, require this medication? And you almost, want to put this in the drinking water. But the thing is that, it's not cheap, right? So this is a big challenge for patients with heart failure. So we were trying to actually figure out if there is a way to understand heart failure better. So this is where we used large-scale proteomics, from the blood, and also combined with genomics. And this is where we use AI strategies together with biostatistics, try to identify the clusters of patients in different groups, and then try to identify the best biomarkers in those settings. I just give you one example today because we have now developed a portfolio of about 8 different markers, but I give one that has the most advanced data at the moment, and that's IGF-BP7. That's insulin growth factor binding protein 7, and it turns out to be a biomarker that's increased in heart failure. It's quite novel. It interacts with insulin receptor, modulates metabolism, but also represent accelerating aging because it interacts with IGF-1 receptor, which is a senescence marker. And so it turns out that if you actually use this marker to look at patients with heart failure, preserved ejection fraction, the area under the curve is about 0.89. So it's not too bad for diagnosing patients with heart failure with preserved ejection fraction. And other groups have already used this marker. So we discovered this marker. Now Roche Diagnostics has developed it into a platform test for the laboratory. And the investigators in the UK and Harvard done the DAPA heart failure study. And you can see that in this particular study, the higher the levels of IGF-BP7, the worse the outcome in terms of death, in terms of hospitalization and all-cause mortality. And also, this is independent of other markers of heart failure, like NT-proBNP, troponin, or renal function. And so that the higher the IGF-BP7, the worse the outcome. But interestingly, what we have found is that, the big question is, does everybody need SGLT2 inhibitors? And in fact, now there are many cohorts, and in which this is the CANVAS program, but this is similar, with the empagliflozin data as well, that if the patient has elevated IGF-BP7, they are the best responders to SGLT2 inhibitors. And if their levels are low, in fact, they have no response to SGLT2 inhibitors. So this is one way for us to actually begin to understand, how to manage the patients with more precision. And in fact, there are more data now we have available to show that it's not only a diagnostic heart failure candidate, it's a good prognostic data. It identifies strategies for treatment. In fact, now we have potential data to suggest that it may be good for also treatment for heart failure itself, as well as it may show brain and heart connection. So we published the biology behind IGF-BP7 in this paper recently, and it's showing that IGF-BP7 demonstrates it's an aging readout for the blood vessels. If the patient has multiple risk factors or has heart failure, preserved ejection fraction, there's an accelerated aging, IGF-BP7 level is up. So the big question is, can you lower IGF-BP7? Does that make a difference? So we have, this is in the clinical data, preclinical data in the mouse model of heart failure, in which if you give antibodies to IGF-BP7, it reduces the dilatation, hypertrophy, it reduces the scarring in the heart, and actually reduces the aging acceleration in the heart itself. And there is also improvement in terms of survival, and there is also decreased lung weight to body weight ratio, which means that there's less heart failure as well. So in fact, currently we are actually developing both antibody as well as RNA-based therapies based on IGF-BP7. But the last interesting thing I just mentioned earlier, that the aging of the blood vessel is not only in the heart, but it also affects the rest of the body. So IGF-BP7 is one of the best indicator of kidney function, but also for brain function in terms of dementia. And indeed, what we have found that this is again a model of myocardial infarction, that after myocardial infarction, IGF-BP7 levels are also increased in the brain. And in the, particularly in the hippocampal region, which is important for memory. And so this may actually indicate the risk of having early cognitive impairment, for example, in patients with heart failure and also after myocardial infarction. And so that the vascular damage or advanced accelerated aging may be throughout the body, and that's why these conditions are all linked. And recently we have got a major grant to particularly look at the brain and heart connection, and this is another area that we would love to have a collaboration. And just then a couple more stories. One is that in terms of imaging, we got excellent demonstration of the importance of imaging, in terms of the laboratory as well as the clinical imaging and in precision medicine. And so we certainly now incorporate AI in a lot of our interpretation, and exactly as mentioned earlier, it gives more precise patient selection, but more importantly, it gives faster data acquisition and also analysis. It gives us more accurate information so that we can actually do the readings better and faster, and so that then cardiologists can go home the same time as the pathologist at 4 o'clock, and except on call, yeah. And so indeed, we have, for example, reading our PET scans, for patients with ischemic heart disease, that adding the AI algorithms give us much better in terms of area under the curve, and give us more accuracy for quantitating and also localizing the ischemia. And this is now part of our routine interpretation. But I thought it was interesting to say that chest X-ray is no longer useful in medicine. But here is one story on chest X-ray that may be still useful, and this has to do with the issue of a pacemaker. Patients can come into the emergency department with a problem and has a pacemaker, and the question is, could be a condition related to the pacemaker, but what type of pacemaker is it? Sometimes patients forget to carry their ID, so it gets to be difficult. And so each year, over 600,000 new pacemakers are inserted, and I did a little calculation, over 63,000 new ones in Taiwan. And but the pacemakers are made by 30 different companies and different models, different uses. So this is a real problem, and you have all kinds of lovely variety of pacemakers, but they do show up on chest X-ray. And so the question is, can you actually figure out, using AI as to which pacemaker it is that the patient has? So it's not really actually a difficult problem, because, you can actually then collect the data on the chest X-ray, have the accurate model there, and have a training set and also a validation set. So Dr. Pascal Thierry-Lausanne, who's a young cardiologist in our group, and looked at the 21,000 patients, with pacemaker, and over 266,000 chest X-rays, and with the proper labeling, and actually did the training, and also then did a subsequent evaluation. And in fact, when you do this, you found out that some patients have more than one pacemaker. And this patient has 3 pacemakers, and they're all different. And so these are kind of interesting problems. And so indeed, you can actually do this quite reasonably well. And of course, mentioned earlier, you require good quality chest X-rays. You must not have motion or other things. Fortunately, chest X-ray is quite easy, and you can actually get accuracy up to 99%. When the data is actually really good quality. And so the other question is also AI sometimes a black box. Can you actually figure out, what the algorithm is actually using to determine which type of pacemaker it is? And you can see that, in fact, using the GradCam type of algorithm, you can see that the algorithm generally uses the pattern of the electrical circuit design, which is unique to each model. That actually is the information that's used by the algorithm to determine the make and also the type of pacemaker that's actually used. So this is now being developed onto an app, so you just take a picture of the chest X-ray component, and it can actually help you read out. So last thing I just talk very briefly is AI precision in healthcare, because for example, Superintendent Chu here, has to look after the whole system. So we have to make his job easier as well. And so how do we actually potentially use AI, for example, in terms of guiding surgical care, in terms of treatment recommendations, but particularly in terms of a health system in management. And I give one example of project one of our cardiologists was actually doing, and so that is that, for example, in terms of determining patient flow, through the ICU, and in terms of the potential duration of stay, complexity, and the type of appropriateness, and the things like that. And so one can actually use a lot of ICU data that's already available, and then one can actually determine what the optimal use of this type of strategy is. And Dr. Louise Sun, who's chief of cardiac anesthesia here, but unfortunately she left us. Now she's chief of anesthesia in Stanford, but she did this work before she left, in which then she actually looked at the data, but this is mainly in patients undergoing cardiovascular surgery, to look at the patient's profile, risk factors, and also ICU stay, to look at the most optimal patient risk prediction, and also the duration of hospital ICU stay to optimize the patient flow. And this was very important, turns out, particularly during the COVID period, because there's also demand, on the ICU by other factors. So this is actually a strategy that is very helpful in terms of resource allocation, together with patient profiling using AI tools. So the last thing I thought is kind of very interesting, looking at the future of AI, and this is just published in Nature. It was Eric Topol and some of the folks from Harvard as well, and that's actually looking at the generalist medical intelligence. So that's no longer just a specific data training for specialized purpose, but I actually begin to use AI in a much more broad model, which I think we all wish that we could actually do this, so that it combines information, from images, electronic medical record, and monitoring signals, the omics, in terms of genetics and other biomarkers, and also the graphic interface, and so that the potential output can include not only chatbots to interface with patients, but also in terms of interactive note-taking. And this is mentioned earlier about natural language models. But the other thing that's actually important are bedside decision support, and even radiology imaging report. And one example, which was published in New England Journal just a few weeks ago, is actually the ability to integrate this data. I think this was kind of mentioned earlier, in the presentation on lung nodules, right? In which you can actually integrate not only the imaging data, but also the clinical information, and also other type of information, but using a generous AI model, so that it's no longer just trained on single parameter, but actually integrate a model so that the radiologist can get the proper reading and information for the radiology report, but also the physician can get this information, but together with decision aid. But the patient can also get the information, but it's in a patient-relevant manner in terms of prevention strategies and follow-up strategies. And so I think the future of precision medicine is really exciting in this AI era. And so I really appreciate the symposium that you have put together. It's really forward-looking, and so that we have in the future more information using genetics to help us to make clinical decisions, and also biomarkers I mentioned earlier, in which you can integrate, the biology as well as the patient's conditions for better treatment, and also in terms of a better categorization of underlying disease, and better in terms of imaging and not only accuracy but also, saving time and resources, and the health system optimization. So really actually have the ability to improve outcomes, more importantly, having happier patients, increase the efficiency of care, and also potentially actually have ultimately better outcomes for the whole population. So thank you so much for your attention.